restriction which was managed by limited restriction. Patient was managed with an end ileostomy and a transverse colon fistula sir at the time. While in the ward sir on post-operatively 4 or 5 sir, she developed bilious discharge from the midline sir, and she was managed as an intracutaneous fistula sir. So we got a CT done. CT was suggestive of a hypodense lesion in the posterior to stoma, which was suggestive of a collection sir. So we had operated, so we had taken for emergency last week sir. Intraoperatively proximally 3 perforations were found sir. The proximal most was around 2.5 feet from 3.5 feet from ICJ sir, which was fashioned as an end ileostomy. Currently sir, patient is sleeping currently sir. She is fine sir. Stoma is functional sir, and she has central line in situ sir, and she is orally allowed sir, and she is stoma output is currently 1200 ml per day. Urine output sir is fair sir, 1300 ml sir. Only issue sir, she is having slough in the midline sir, which we are doing dressing sir, and she has fever sir. 104 sir, last night she had one episode sir. Otherwise sir, investigation wise also sir, currently she is on injection magnus and tigecycline sir, day 11.
Anything? Gokul that he has missed out? That is Gokul.
Yes, sir. The patient is having fever since last 20 days. We are currently ruling out the causes for fever, but currently all tests turned out to be negative, all the fever profile
But there
tests.
is a clear-cut indication. SSI is there, no?
Yes sir, midline is.
So what do you have to rule out?
Yes, sir.
There is SSI.
Yes, sir.
How do you classify or grade SSI, Terry?
So we use the asepsis score, sir, and we grade them, sir.
Right. What is the score like?
So I don't know the exact, sir.
Okay. Who's going to answer?
Exercise can be superficial, deep, and organ space, sir. And it can be divided on the on according to Southampton scoring and Southampton scoring, sir.
So Southampton is one. And any other score?
Asepsis score, like he mentioned.
What is that?
So it is
Additional treatment required or not, cell sanguineous discharge, A for erythema is present or not, P for the purulent discharge, and asepsis.
No worries. So
Hospital stay also.
duration of hospital stay also get included. So what would be the score here, roughly, Himanshu?
So roughly around so it's around more than 10, sir.
So in any case, anything more than 10 would mean what? Bad score?
Yes.
Prolonged SSI which will lead to prolonged hospital stay.
So it's going to increase your hospital stay. So what 1 to 3 steps that you would take to fix her? If you're the registrar who is managing.
So if we are suspecting,
If this is the case, what would you do? Tell them
so since there is an SSI and there is a clear-cut source of infection, so we'll do source control, sir. And we'll first we'll start empirical antibiotics and then send culture accordingly, and then sir we'll narrow the antibiotics, sir. And meanwhile we'll also do source control in the form of peritoneal lavage, sir, and daily dressing, sir.
Dressings to be done to rule.
No, what he has said, don't repeat. Anything more, Ram?
Sir, sir, will do the dressing, debridement, and send pus culture, sir. Narrow the
So all
All of you
nutritionally,
forget
sir.
something,
Manage
yes.
nutritionally.
So that's why I was waiting you will talk. We ignore nutrition, which should be supported. Because nothing heals unless your albumin is okay. So what is the albumin
So
globin
1.8,
ratio?
1.8.
So we are doing fine there. And the answer to low albumin is not albudac. We need to correct the calories
Cause of the
and
we
the
need to-
cause. And sepsis causes catabolism. So that itself will produce a malnutrition of nature. With malnutrition, the proteins are deficient, and proteins are necessary for tissue building. So in any case, it doesn't do any good. You can add antibiotics, you can keep on doing many things, but if you don't have adequate proteins in the body, healing won't happen. And the ability to combat sepsis would not be there. Okay? So don't miss out on that. Nutrition is important. Daily debridement is important. Dressings are important, which become a part of hospital debridement. And preventing dehydration becomes important, which is D again. And then do the usual correct things about culture. What culture would you order?
Sir, I would order a deep deep tissue culture, both aerobic
One
and
deep tissue for aerobes.
aerobics and anaerobes.
And also fungus. They are immunosuppressed, so anaerobic infection, fungal infection, all becomes an issue, and you must be very, very careful in making sure that you get the actual reason for persistence of sepsis. And so to repeat it for the first years, these are patient related issues. Then there are those that are related to the surgeon also. What surgery was done, was it optimum, there was some infection due to technical reasons which we need to take care of. And thirdly, when do you want to intervene and what would be your intervention?
Sir, in this case, I would not like to intervene, sir, because patient is currently in catabolism, she is in sepsis, sir. I would like to build her up both nutritionally and biochemically, and then plan for a definitive abdominal wall closure, sir. Meanwhile, I would like to manage her as an burst abdomen. Open abdomen. And
That's very nicely answered, and he gave a balanced answer. That I'll build her up, make her suitable for that treatment, and that would mean taking care of the catabolic state, making her nutritionally good, and this is not the right time to be intervening. It will cause problems. So don't be in a hurry to close the abdomen, because then you will be burying all the problems inside, and they'll come out as a major issue with anaerobes really enjoying the anaerobic environment. Leaving it all open is lots of oxygen, so anaerobes won't grow. And that's how you manage. What are the fluids you ordered?
so fluids, sir, currently she is on injection TPN, sir, which comes around to 1 liter, sir, and otherwise we ordered 4 vax, sir, D5 and NS, sir, along with a multivitamin infusion in that, sir. Otherwise she's only allowed, sir. So electrolytes, sir, we are managing only with ORS and
Arun, why should we insist on enteral feeding more?
So because enteral feed is the natural, we should prefer natural process whenever it is possible. And sir, if we use parenteral nutrition, first we have to insert a line, center line. That will be a source of infection for the patient. Plus, sir, in parenteral nutrition, the intestinal villi, they go atrophy. And that's why we have to prefer enteral nutrition more.
Very nicely answered. Anything to add as second year?
Along with the atrophy of the villi, there is an imbalance in the intrahepatic circulation also, and translocation of the gut, which again leads to the additional problem of the thing. So all this could be managed by all this could be just managed by giving her orally, sir.
Enteral is physiological, as you rightly said. Gut atrophy can be prevented if you use enteral. If you use guts, you don't lose them. Thirdly, transgut migration of bacteria would happen, which is a major killer that lead to septicemia due to gram-negative organisms, can be killer. And there's a gut-brain axis that I talked about in my oration, which we ignore, that leave those big holes in it. So it can be a challenge to keep the gut intact. So integrity of gut is very, very important, and that is achieved by enteral. Suppose you cannot give this patient adequate nutrition in any case, you can give even sips of water as long as the gut is moving. There's one thing you all missed, you also missed. So if there is gut is not used, the bile duct also doesn't move. So there is cholestasis, which leads to jaundice, obstructive jaundice, and then you cannot give nutrition. Have you understood, students? Villus atrophy, it's more physiological. It doesn't cause the gut to lose its integrity. There is no transgut migration of bacteria. There is no cholestasis, which can lead to jaundice. And fifth, enterohepatic circulation of bile. Because bile keeps getting reabsorbed. It's necessary. So always keep the gut in use, whatever length of gut you have. It may not be a complete gut. You may not give her all the food that you take. So she doesn't necessarily have to take pizza now, but she can take some water. Something should go. But don't keep the guts absolutely without work and function. Okay?
He had alleged issue of road traffic accident on 8th of November, sir, during which he suffered. So patient is a 25-year gentleman, sir, with alleged history of RTA, road traffic accident on 8th of November 2023, during which he suffered injuries to his head, chest and abdomen, sir. When he presented to us with shortness of breath and pain abdomen, sir. At that time, ultrasound fast was suggestive for EFAST. EFAST was positive in view of right hemothorax and free fluid in the peritoneum, sir. We got a CECT whole abdomen along with NCCT head done, sir. So from top to bottom, he had pneumocephalus, sir, multiple maxillofacial fractures, sir. He had 7th to 7th rib fracture, sir, and right moderate hemothorax and grade 4 liver injury in the abdomen, sir, with no other associated solid organ injury, sir. At that time, sir, patient was vitally stable, so he was managed conservatively in the ICU, sir, as per protocol, sir. He was shifted to ICU, sir, last week, sir. Currently, sir, patient is GCS is 10/15, sir, and sir is vitally stable, sir. He is on oxygen 2 liter. Saturation is 98%, sir. Bilaterally, sir, air entry is present. There is slightly reduced air entry on the right side, sir, on account of hemothorax, sir. ICD is draining around 10 ml, sir, daily, sir. Abdomen wise, sir, his per abdomen is soft. There is no guarding rigidity or tenderness, sir, and he's allowed on account of poor JC, sir. We started him RT feeds instead of oral, sir. So for that he's and also he's passing student flatus, sir. Sir, only issue, sir, is this patient is decreased consciousness, sir. We got a repeat NCCT head done which revealed diffuse cerebral edema, sir. On metabolic profile, sir, he had chronic hyponatremia, sir. 121 was the last sodium, sir. So we have started him on sodium correction, sir, and for cerebral edema we have given him mannitol, sir. Patient GCS from last night it has improved, sir. He is now responding to command, sir. Today's GCS would be, sir, around 12/15, sir. Otherwise, sir, we have and also patient, sir, complaining of paraparesis, sir, for which we have done X-ray, sir, but X-ray suggestive of no any bony injury, sir. So we have got an MRI spine which is scheduled, sir, next week, coming week, sir.
Anything to add, Ram? His respiration doesn't look very good. The accessory markers of respiration are reduced, and you've got jerky respiration and some bit of paradox you can see. I don't know what are the fractures like.
There is no 7th to 7th right rib fracture, but there is no plain segment.
I would be very careful in that assessment because I can see this part having a plane. This is going in, right?
Yes, sir.
On inspiration, the rest of the chest should move, whole chest should move outward. But this segment is going in. You can see that paradox. So, with this flail, we don't have a problem with the GIT. Pneumoencephalus was the problem, which would indicate breach somewhere in the base. No CSF rhinorrhea?
No, sir, no CSF granular notoria, sir.
How will you differentiate this rhinorrhea from the usual nasal discharge?
Actually, we can do a test called bedside handkerchief test. So in this we have to collect the discharge in a handkerchief, and if it is a CSF, then the handkerchief won't get stiff. If it is a normal discharge, nasal discharge, it will dry up and the handkerchief will get stiff, sir. So next we can do beta transferrin assay in biochem. We can send the sample for beta to transferrin. And thirdly, sir, we can check for a sign called halo sign or target sign, in which we can collect the discharge in a blotting paper, and we can see whether if it is a CSF rhinorrhea, we will get a drop of blood in between surrounded by an halo.
So CSF rhinorrhea won't stop on application of
Snip.
sir, on hanging.
If there is blood in it, it won't clot. Blood mixed with CSF does not clot. Blood mixed with bile does not clot. Blood mixed with urine does not clot, unless there is more blood than urine. They all have fibrolysin, right? Blood mixed with acidic fluid does not clot. So the usual system, hemobilia, the blood in the bile, does not clot unless the blood is so much that bile is less. And due to fibrolysin doesn't let the fibrosis happen. The clots don't form because that's natural. Otherwise, you will get blocks everywhere, in your system. Similarly, here CSF is mixed with it. And another thing is to test for sugar. You'll find the sugar levels are high with CSF mixture. Unless the patient is a diabetic, that is a different story. And there is also a diabetes of trauma. What is that, Karan? What is the diabetes of trauma? You finish your MRCS, so you should be able to answer that.
Because of the stress, so there is hyperglycemia to make up for the stress that the body is going through. There is insulin
There is-
Because the corticosteroid and the adrenaline beta 2 agonist, both of them are cause increased blood sugar levels. Sir.
So it's a good news or bad news?
So it is good news for some time unless it goes out of control.
Sir,
That's an art of answering. What did he say? It's a good news until such time when it goes out of control, which is the answer. So that's well answered. And it makes an impact. If you answer properly, every examiner thinks, balanced head. So whenever he'll work, settle down to be a focused worker, he'll do well. Because he can comprehend. And then importantly, communicate. You may comprehend, if you don't communicate, it doesn't work. Not that you have missed any points, but this point is important, right? And these tests are very simple, they are bedside. So halo side, put on the chief, CSF here, halo around. Blood in it doesn't clot. Sugar is high. What are the do's and don'ts in a patient who's got CSF rhinorrhea? Do's first. If you don't know, say you don't know, so that you can save it.
So first we should suspect anterior cranial fossa injury. We should check for.
Okay, you suspected it. What are the do's? Obviously, it's an injury to the base of scalp. Sabya.
cervical collar stability we can provide.
Okay.
Don't know, sir.
You don't know. Record so. To say don't know, why why taking so long?
Pressure. CSF.
Acha, you are.
Sir, will prevent development of cerebral edema, sir, and anti-epileptic should be started.
Okay.
So
you don't know.
So
antibiotics.
don'ts would be no no hypotonic solution should be given because there could be head injury.
So not in-
So avoid D5, sir.
NG insertion should be.
Kya baat? You want to answer that? Oh, D5. Who is going to give D5 anyway? D5 also causes some bit of diuresis. It reduces edema, sir. The do's are after I tell you the don'ts. Don'ts are, don't pack it. This nose should not be packed because this is a natural burr hole. What is burr hole? You create an opening into the space, right? So here it's a natural burr hole. If you block it, intracranial tension would rise. You don't block it. If the patient is conscious, avoid sneezing. Why? Air is sucked in after sneeze. Pneumoencephalus happens due to that. Yeah. 3. Start antibiotics. These are the do's. Don't keep the patient head and up. Why? The leak would increase. So should he be head down? No. Neutral position. And what's the neutral position for head injury? Tonsillectomy position. What is tonsillectomy position? 3/4 prone. Okay. Antibiotics I've already told you. You don't necessarily need to do anything active. So don't intervene. Later on you can put a patch at the base, which can be a dural patch, it can be some fascia. There are artificial patches also available. This is how you manage. Is it clear?
Yes, sir.
It applies to CSF rhinorrhea, to CSF otorrhea, both. The rest is all bunkum. Don't give this, don't give that. And that is a part of head injury management anyway. So manage it like you do any head injury management, where you can give mannitol or a D5. You said D5 should not be given. D5 can be given. It is given actually because it causes reduction in edema. You have understood, all of you, what I said? So this is necessary in all these patients. A lot of us will just put the head up because of the tongue fall problem. The tongue falls more often if you keep the patient in this position. It's better to keep the patient 3 foot tall. They call it tonsillectomy position. Post tonsillectomy, that's how they used to keep patients earlier. The bleeding should not happen. Is that clear to all?
Yes, sir.
It's got some element of flail. How do you take your decision?
So for flail chest management is earlier reflexation was to be done, sir. Now it has been abandoned, sir. Now it is usually intermittent positive pressure ventilation, adequate
This was
analgesia.
abandoned, I think, 25 years ago.
Yes, sir. It was now not done, sir. Yes, sir.
How is 25 years ago you were born? So it was abandoned that time. And fixation has got no role. Strapping is obsolete, contraindicated. Why is strapping contraindicated?
Decrease the chest volume.
It reduces ventilation. And this is paradoxical movement. So we can provide some splint. Which splint you'll provide?
So we'll do intermittent positive pressure ventilation, pneumatic splint. Pneumatic.
Internal pneumatic splint is lung.
Yes, sir.
So you control the ventilation, so the lung acts as a splint, air-filled splint. So control your respiration. If you don't have the facility for IPPV, tracheostomy, to reduce the dead space. But everything today, the only thing that has changed is ABG. Assessment of ventilation is important. Pain management. By doing intercostal blocks, and IPPV and epidural blocks are considered a standard of care. They really help. And what do you use for the epidural block, Sabya?
Sir, patient own, sir.
So we use bupivacaine and lidocaine mixture, sir.
People use morphine also now. Why is morphine contraindicated in chest injury? This is a pharmacology.
It inhibits the respiration.
So it causes, it's a central. In fact, morphine suppresses everything in the brain except 3 centers. What are those? Yes, louder. CTZ, no? Vomiting center 2. Third nerve nucleus, so pupillary constriction. And third, this is a pharma question. Sympathetic overstimulation. Okay. So everything goes down. So respiration goes down. But by virtue of pain relief, the ventilation improves in small doses. You need to titrate the dose. Then morphine in small doses is good. There is a WHO ladder of pain management which we should follow. But these patients require either this or intercostal block or epidural. If the ventilation is taken care of, if it is pain-free, and if you can have internal pneumatic splinting. Perfect. Clear now? 50 things. Provided you are here and you are alert. I can bet on it. You go to many coaching classes, do their MCQs, this won't come. They are not going to talk about it. This is not what they're wanting to do. Understanding is more.
23 gentleman, sir, came to us with complaints of pain abdomen and non-passage and student flutters for the past 5 days, sir. On examination, sir, he had tachycardia, sir. He had his respiratory system and CVS was unremarkable, sir. On per abdomen, there was epigastric tenderness and guarding, sir. The rest of the abdomen was distended, sir. And there was shifting dullness also present, sir. We got an ultrasound and CT done at that time, sir, which was suggestive of a acute necrotizing gallstone-induced pancreatitis with modified CT severity score of 8/10 with peripancreatic collection, sir. At that time, he was shifted to ICU for some management, sir. Since then, he was actually intubated in ICU and extubated also, sir. Then he was stabilized and shifted to our side, sir. During the ICU stay, he also developed abdominal compartment syndrome, sir, because he had abdominal distension and his IAP reading was increased, sir, along with onset of oliguria, sir, for which drain was inserted, sir. Drain is grading currently around 200 ml seropurulent, sir. Sir, today's on morning examination, sir, his Apache was 8, sir. BP, sir, is 119/76, pulse rate is 96, sir, and he had 1 episode of fever, sir, last night, sir. And sir, drain is draining around 200 ml seropurulent, sir. Respiratory examination, sir, left side there is decreased air entry in the basal side, sir. Earlier there was bilateral, sir, so we had got an X-ray done which was suggestive of bilateral pleural effusion, so we had done TAP, sir, which drained around 100 ml on the right side and 50 ml on the left side, sir, serous fluid, sir. So we had sent for examination which turned out to be reactive, sir. Currently, sir, he has left-sided decreased air entry, sir. And abdomen, sir, his abdomen is distended, sir. His bowel sounds are present, but he's not past stool and flatus, sir. And Otherwise, sir, his urine output also is, sir, adequate, sir. Urine output is 800 ml, sir.
So you're suggesting that he's getting better. First of all, I must compliment him as a registrar. The way he has presented the case would be a lesson for the postgraduates to learn. The hunky-dory presentations don't help. He has summed up everything in it. He talked about the etiology of the pancreatitis, he talked about the severity of pancreatitis, he talked about the scoring, he talked about the Apache CT severity index, he talked of the intra-abdominal hypertension, and he talked about what is coming out of it, and he's talking about what is happening now, and in terms of the Apache score, he has said patient is getting better. So I don't have to ask anything as far as he's concerned. That was a brilliant way to present it. Okay, I'll ask him a different question. So when the IIP was raised, how was the drain going to help?
Sir, actually when the IIP was raised, sir, IIP was raised along with there was oliguria, sir. So we had made a diagnosis of abdominal compartment.
No, that's what I'm saying. If the patient had abdominal compartment syndrome, don't take home a message that you can manage it by drain. The answer is decompressive laparotomy. But here, the cause for this rising tension was collection, which could be established on CT. Since it could be established, releasing that can take care of it. But the answer to abdominal compartment syndrome, and he mentioned intra-abdominal hypertension with oliguria. So intra-abdominal hypertension with one of these kidneys, lungs, or brain, or heart getting affected is abdominal compartment syndrome. So what is abdominal compartment syndrome, especially? I just said.
So, increase in intra-abdominal pressure plus any of the 4 organs involved: kidney, lung, heart, or liver.
Repeat.
Any of the 4.
Repeat what I said.
Increase in the intra-abdominal pressure and any of the 4 organs affected.
That will be abdominal compartment syndrome. Otherwise, it's called intra-abdominal hypertension. What is the normal pressure?
So less than 12 centimeter of water, sir.
Water or mercury?
Water.
How do you measure it for their benefit quickly?
So we can
rapidly?
measure both directly or indirectly, sir. Directly we can introduce a probe into the abdominal cavity, which is measured via machines, and indirectly, sir, we can measure it by a Foley's catheter in the bladder. So first we'll empty the bladder, then we'll instill 50 ml of saline and clamp it, sir. Then we'll attach a CVP manometer to it, sir, and we'll keep it at either we can keep it at the pubic symphysis or at the sternal level. For sternal level, we have to subtract the height, sir, and then we'll release the clamp, sir, and we'll let it normalize, sir. The level at which there's a ball marker, sir, which stabilizes, sir. The level at which it is the marking.
Excellent. Right. And if you plan decompressive laparotomy, what precautions would you take? Let me complete with you so that I can save on time. What precautions would you take? Okay, what is decompressive cocktail?
So decompressive cocktail consists of, sir, 3 things, sir. Bicarbonate, sir, Lasix, and normal saline.
Because we expect reperfusion injury, splanchnic pooling, hypotension. So we give fluids. And these, you also expect acidosis because of the contents of reperfusion going into circulation. So give soda bicarb. And you expect pre-renal failure or renal failure due to flow not being adequate. So we give diuresis. And a lot of people prefer now giving diuresis with not mannitol but with Lasix or furosemide. So this is optional. But furosemide causes that dilatation in the part of it, does a better job of it. How does it function? Which is separate?
Furosemide is a loop diuretic, sir.
It works on the loops, convoluted and
Loop of Henle, sir.
loop of Henle. So since that is more effective in this case, the cause for failures are, I've already told you. So decompressive cocktail should be given before you do decompression. Otherwise patient will have a drop. And what is reperfusion injury? Nidari?
Reperfusion injuries, when we give oxygen to the tissue and there is free radical formation and it damages the tissue. So in long-term hypoxia, there are during the ischemic changes occur in the tissue, but when we reperfuse the tissue, the ischemic elements and free radicals, they come out and it also causes damage to the surrounding tissue.
Understood? Reperfusion injury. It happens in the limbs, also happens in abdomen. When there is a compartment syndrome, anaerobic environment exists. In anaerobic environment, there are more of lactates, acidotic materials. So you perfuse it, it will go to the system. That causes more damage. It's very important to take care of reperfusion injury. Okay? Now, when do you intervene in this case? Do we intervene or we are okay?
So this is a case of necrotizing pancreatitis, sir. I will, as per the guidelines, we will like to do a step-up approach, sir. First, we'll try for ultrasound guided, any guided drainage, sir. In this patient, it was not possible, sir. So we had introduced a drain, sir. Next step would be, sir, any endoscopic procedure to do retroperitoneal debridement, sir. VARD, it is video-assisted retroperitoneal debridement. If that also fails, then we'll go for open surgery and do necrosectomy.
So first we make a diagnosis if that necrotizing collection is infected or not.
So we need to know the indications for necrosectomy. And indications are number one, necrosis more than 50% or infected necrosis. But before that, these are 2 and 3. Before that is number one, patient symptomatically getting worse. The clinically patient is getting worse, so it becomes an indication per se. And you should have a step-up approach, he's right. And necrosectomy is not a joke. You can create problems. So try to work with guided drainage. You can put the drain in the lesser sac. The second is endoscopic or laparoscopic necrosectomies can be done. Or thirdly, you can do an open approach. An open approach can be supracolic or infracolic, because you can approach the lesser sac from above as well as from below. Most of us like to approach from above because it is easier for us. From below, another risk is damage to the mesocolic artery and also the the supply to the colon. So this can be something you look for and make sure that you
So this patient be a candidate because he's having fever persistently.
fever you already have got us infected necrosis, but also CT severity index is
The
coming.
repeat CT also done. It is all suggest same status, sir. CT is head button and collection.
The other thing is the golden hour of surgery in gallstone-induced pancreatitis. If the patient presents in 48 hours or early, we can do endoscopic retrieval of stone. That relieves symptoms to a great degree, because the whole concept of pancreatitis is stone blockade at the opening or some edema or whatever, and intraductal hypertension leading to rupture and then enzymes digesting themselves. So you need to be clear in your mind that it's IDH that is kind of starting, and hypoxia. Have you understood? IDH, intraductal hypertension. If you tube block it, hypertension, the secretion is collecting and then it ruptures, and then it digests the pancreas. And the most important morbidity is in patients who are obese. So obesity is a risk factor because there is more fat and lipase is there, which can cause fat necrosis. So more fat means more necrosis, and more necrosis means bad outcome. But CT severity index also helps you take a decision about surgery. All these factors have to be taken collectively, and we don't replace patient the features. This transverse stretch of the umbilicus is indicative of fluid, and if I feel it, there is some collection here, but not as much, and there is some necrotic material which collects in the form of phlegmons, which have been given a name, aseptic necrosis or walled-off necrosis. We will wait for it to settle down because patient looks better to me, vitally. Infection, you intervene, you got to drain in. This is not the case where you find out an FNAC. The CT guided FNA is required to get the culture to send it for bacterial infection. Now there is no rocket science. It has to be potentially infected. You intervened already. So that criteria goes off the window. Fever could be due to intervention. The fever due to necrosis is what we were talking about. So understand the difference. That's the first time you find out. It's like, if you catheterize the patient, you can't do culture sensitivity through the catheter.
Yes, sir.
The whole thing, the logic should be understood. And I would suggest get the catheter out and gradually reduce the size and shift it to, if you can pass urine on his own.
We plan for a condom.
Plan for a condom. So it's already condom. Why don't we keep the catheter for long?
Site for infection, it will.
Very good one. Why infection?
So the foreign material.
Foreign body. Next.
Uncomfortable for the patient.
Third. They all correct. Third I want. Problems with tube in a tube. That is the question. Tube in a tube. adhesion formation. They're just guessing. No, that's not correct. Anything else? You gone bonker. Okay, so they don't know. Any tube in our body, I mean any tube, there is mucus produced to keep it lubricated, yes? 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 And then it can't be there forever. So there are cilia which push it out. So some it's coming out with urine or otherwise. Let's talk of urethra. The cilia have a very important action to keep the mucus out, to keep the secretions out. By putting a tube in it, you block the ciliary action. So mucus would collect. Stagnant mucus would become infected. And infection leads to fibrosis. And that leads to strictures. How can we prevent it, if I may ask you an intelligent question? I mean, a question is silly, intelligent answer. Well, so the reason I told you, if you can't think that quickly, I can't wait. Reduce the diameter of the catheter. So before you take the catheter out, management of catheter is extremely important. Pull the catheter, clean it every day. That is catheter management. Pulling, because it's inside always. Pull, clean, and let it go. You can use betadine, you can use saline or something. One. Gradually reduce the size of the catheter so that there is breathing space for the tube. The cilia would continue to then function. Have you understood? Same is the reason. It's not always a tube, air block. These are very, very vague answers. But now I've given you the definite answer. That is the science behind it. So we can automatically put it through. Well, like we do for tracheostomy. It's not for an airway that you keep reducing the size of, they say decannulation. It is to reduce, allow the mucus to move. Otherwise, tracheitis, stricture. Because of fibrosis later on. Is that clear?
Yes, sir.
So anywhere, whatever tube you put inside another tube, anywhere, now you can make 10 MCQs out of it, okay? Catheter in the ureter, nasogastric tube in the esophagus, tracheostomy tube in the trachea, 3 questions ho gaye. Baat ek hi hai. That's your MCQ. That's your need, speed, whatever names you give it. Intellect is not tested. This is where you should understand. Perfect. We'll take a decision accordingly.
20th gentleman, sir, came to us in emergency on last Wednesday, sir, with complaints of pain abdomen and non-passage on stool and pretus for the past 4 days, sir. Sir, on examination, sir, he was tachycardic, sir, and tachypneic, sir. His abdomen, sir, there was generalized guarding and rigidity present, sir. X-ray was suggestive of gas under diaphragm, sir, in the under the right hemi-diaphragm, sir. His pre-op Apache, sir, was 12, sir. On intra, he was taken up for exploratory laparotomy, sir. Intraoperatively, he was found to have 2.5 liter fecopurulent contamination in the peritoneal cavity, sir. And there was a 2 into 2 centimeter perforation half feet from ICJ, sir.
What is the likely etiology looking at his condition?
So we are suspecting typhoid, sir, entry.
He's got the Hippocratic faces. He's malnourished. Typical features of typhoid. 3rd week and presenting. 3rd week is the commonest type of perforation, right? You know, remember the testing for typhoid, we used that mnemonic Basu. So I had a friend whose name was from Basu. Pull him up for that.
So we had made a
blood culture 1st week, agglutination, that is Vidal 2nd week, stool 3rd week, urine 4th week. So 3rd week is when it's in the gut, that's when it perforates. But gallbladder can also perforate, it comes via gallbladder down. That's why that typhoid Mary story of gallbladder. Carriers can keep it there so that they can keep throwing for you. They will remain all right. The carriers don't fall sick. That's the beauty of carrier.
So we had made stoma, sir, 2 feet from. We had done primary repair of the perforation to half feet from ICJ, and we had made a stoma 2 feet from ICJ, sir. Sir, he had developed midline SSI for which we had removed the proline and bursa. They were
still having tachypnea because he is malnourished. And there's
half
bit
an
of
hour ago,
infection.
sir, his stoma also receded, sir. So we are planning for reoperation.
Let's see the story. So you can see now this patient has got into an emergency. Torch here.
It's going inside, sir.
So we need to redo this surgery because stoma is receded. This is for surgery for. आप ठीक हैं, घबराएं नहीं, हाँ? ठीक हो जाएगा. ठीक है, आराम से बिल्कुल रिलैक्स होकर के सो जाएं. आज आप ये भी प्रॉब्लम आपकी ठीक हो जाएगी. थोड़ी कमजोरी है ना, उस वजह से हुआ है, ठीक हो जाएगा. One is any complication. Which prolapse, how much of prolapse? 10 centimeters or strangulated prolapse. Receded, parastomal hernia which is strangulated. These are indications. And you can take it up in emergency today. It has to be brought out. Since he is malnourished, so there are patient-related factors also. So hitch it using 3-point fixation, which we normally do. And make sure that skin hitch is not lost, because that is going to hold. Don't rely on muscle, the sheath only. Don't be a classical stoma fixer. You should keep it, at least the last barrier should stay. They are, because of malnourishment, this will happen. And there is something called as Zenker's degeneration that happens in typhoid patients. What is Zenker's degeneration?
It happens in the Peyer's patches of small intestine due to
It happens anywhere, in the abdominal wall also. Due to
lymphoid means hyperplasia.
Zenker's degeneration is a physiological teaching, which is the myopathy muscles. So they go weak. So here also they go weak. Peyer's patches cause infection. Peyer's patches has nothing to do with the wall. They have thinned walls. They have weak muscles. That's the concept of Hippocratic facies. They heal poorly. Wound dehiscence is common. Therefore, you should leave it open like we did here. So we've done laparostomy, and we will not intervene immediately. We will try to build him up and manage it as an open abdomen, and we will accept a hernia, ventral hernia, over killing him right now. So what is this called as? Bailing out? No. Living today to fight another day. Right? There is no point. I mean, a living problem is better than a dead solution. So don't provide everything today. It won't live. So let's have that living problem.
21-year-old male, sir, who initially presented to us in the month of September with alleged issue of RTA, sir. At that time, he was found to have a grade 5 splenic injury for which splenectomy is done, sir. So 4 days ago, he started developing pain, abdomen and non-passing. X-ray was suggestive of air fluid level, sir, and ultrasound was suggestive of multiple dilated bowel loops, sir. We had made a diagnosis of intestinal obstruction, sir. And we had taken him for extracorporeal laparotomy, sir. Intraoperatively, there were dense adhesions present between bowel to bowel and bowel to parietes, sir. And there was bowel twisting around, and we had released the band, sir, and untwisted the bowel. It was
ठीक हो? और समस्या पकड़ी गई, ठीक हो गए अब आप, हाँ? अब चिंता नहीं करेंगे, ठीक है? चिंता करोगे तो फिर ठीक नहीं होगा.
So there was a cecal perforation in the cecum, sir, 2 into 2 centimeter.
How did the perforation in cecum happen if there is distal obstruction? For their benefit, tell them.
So it was for kind of a closed loop, sir, because ICJ was competent at
closed loop obstruction. Why does cecum give way in closed loop obstruction?
Because it's a fixed structure.
Fixed structure.
So because the wall is thin, sir.
So because of the Laplace law, sir, it is a distensible structure.
It is Laplace's law. What is that law?
So T is equal to pressure into radius. Tension is equal to pressure into radius.
Louder?
So tension is equal to pressure into radius.
So how would it apply to cecum?
So when the
Continuous obstruction, it balloons out, the wall gets thinned and it ruptures. Wall gets thin because of the blood supply. If I expand current into current, your skin would give way because blood supply won't reach. He has adapted it gradually. This is a sudden process. That is why sudden is also important. If you give it time, then it can continue to grow. But since it is acute, the wall gets very thin, balloons out and it gives way. That is blind loop obstruction leading to cecal perforation. And you manage it by stoma, rarely by cecostomy, but depending upon the situation, the stoma would bring him back to normal. So something which can happen. And why do you say it is a adhesive intestinal obstruction? Because of the patient presenting post-surgery after 4 weeks. The definition of adhesive obstruction is 4 weeks following surgery. Less than 4 weeks we call it pseudo-obstruction only, which can be due to many factors. Adhesions don't form in that time. So 4 weeks onwards, post-surgery, if the patient comes to you, post-abdominal surgery, comes to you with obstruction, it's taken as adhesive unless proven otherwise. The diagnosis is made based on contrast enhanced CT scan. And that's a standard. What is the gold standard for intestinal obstruction? CCT, contrast enhanced CT scan. And what is the short version of it? X-ray erect and supine abdomen. But that is okay to find out. But CT is mandatory because it tells you about the vascularity, tells you about the etiology if required, it tells you about the other features which can be assessed. धीरे-धीरे सब कुछ शुरू करेंगे, ठीक है?
We a gentleman, sir, known alcoholic, presented to us in emergency with complaints of pain in the right side of abdomen and fever for the past 10 days, sir. Sir, on examination, he was tachycardic, sir. Abdomen was distended. There was right-sided, sir, tenderness was present and hepatomegaly was present, sir. And there was right iliac fossa tenderness also present, sir. Sir, on ultrasound, there was it was suggestive of a right lobe liver abscess in segment 5, sir, of approximately 540 cc with a 2 mm rent, sir, with collection in the hepatorenal space and in the tracking down into right iliac fossa, sir. So since he was vitally stable and there was only localized tenderness, so we had gone for a minimally pictal approach. We had done pictal catheterization of both the abscess cavity and the right iliac fossa collection, sir. Since then, sir, the patient is stable, sir. Pictal is draining around 50 ml, sir, of the abscess cavity, sir, and right iliac fossa cavity is draining around 20 ml, sir. Otherwise, the patient abdomen is fine, sir. He is passing stool and flutter, sir. We've allowed him orally. And since he is also a known alcohol consumer for the past 30 years, sir, we are giving an injection thiamine and vitamin K also. Otherwise, the patient has no issues, sir. He's stable.
What's your impression, Arun? What do you make of it?
I think it was managed.
No, you only manage it. I'm asking you, why did you put in, what all has been done according to you?
So, since the tenderness was only local and there were no signs of diffuse peritonitis, so we managed by minimally invasive pectoral insertion and we did not do a laparotomy.
Very good. Answered well. And now, when would you do laparotomy in your patient, suppose in this situation?
So, if initially during the initial presentation there was signs that diffuse.
One is that there is peritonitis, you'll do that. Number two?
So if the rupture is outside the peritoneal cavity, is it in the pericardial cavity?
Very good. If it goes out of control and goes into retroperitoneum or it gets into the pericardial space, then you have to intervene again by step-up approach. Remember what? Step-up approach, which he mentioned. What is that approach? Step-up. Do you also have a step-up ladder for pain management? No? Same thing. We should not just give the last analgesic in all patients. There is a WHO ladder for pain management. There is a ladder for this also. Presently, patient is getting better. Don't bother about anything else. Patient comes back to you, you discharge him. He comes back to you with an ultrasound and says, my abscess is still there, although I am fine. How do you explain that?
Sir, we will get an ultrasound to see.
Ultrasound, you bring the ultrasound.
So we will see if the content is organized or if it is still aspirable.
I am asking you for a reason because you are answering well, that's why I am asking.
I will start the patient on double dose later.
Sir, radiological resolution takes time, then clinical resolution
takes longer, so it may not resolve radiologically, but the space would still be there, and you would like unless a radiologist knows that this was so many weeks old, he would be commenting it as an abscess only. The patient will get alarmed. So the radiological dissolution takes a little longer.
Gentleman, sir, presented to us 2 weeks ago with complaints of pain abdomen and constipation for the past 7 days, sir. Sir, on examination, his abdomen was distended, sir, with bowel loose palpable, sir. X-ray was done, which was suggestive of a coffee bean appearance, suggestive of sigmoid volvulus, sir.
Coffee bean appearance. You've seen a coffee bean? Then it's okay. Otherwise, we keep talking about these things we not have seen. Like anchovy sauce, unless you see it, how would you know what is anchovy sauce? It's like kidney is bean shaped, bean is kidney shaped, and both are like each other. Lymph node is bean shaped, kidney is bean shaped. What is bean like, you don't know. And when somebody is asking what is bean like, kidney shaped. Right? So coffee bean is like a bean only.
Sir, at that time, sigmoid volvulus diagnosis of sigmoid volvulus.
What are the other radiological features of sigmoid volvulus? Sorry.
There will be coffee bean.
हो गया ना, coffee bean is one.
Fryman-Dale.
What is Fryman-Dale sign?
So try radio.
3 radiopaque lines converging into the right iliac fossa. There's an X-ray, lines 2 and 3. Clear now? Like this. right? And coffee bean looks like a coffee bean. You know, there are all these signs which confuse. Yeah, there is an X-ray. Put it on the screen there, no? We'll discuss it there. What was done to the sigmoid, dear?
So intraoperatively, there was a approximately 30 centimeter long redundant and sigmoid colon present, sir, which was highly mobile, sir. Sir, transverse colon was also highly mobile, sir, approximately 20 centimeter in length, and sir, ascending and descending colon were also highly mobile and redundant, sir, considering the fact that they recuperated also, sir. So at that time, because patient also has repeated history of constipation, sir, so we had gone with the decision to reset the sigmoid and fashion it as a loop colostrum, sir.
Okay. Now, who gets it more often, vegetarians or non-vegetarians? Why?
To digest the cellulose extract, so to digest the cellulose
You
component.
eat cellulose?
No, sir.
That's in the rabbits, man. Or cows. When did you have cellulose
No,
last?
sir, no, sir. That,
No, let me know. I would be interested. When did you take cellulose last, Sabya? It's a very tasty thing to do. But where do you get cellulose from? You will have to tell us.
cellulose are plant-based.
Grass, no?
Yes.
So when did you have it? Okay, never mind. What he's trying to say is, in all vegetarian animals, since they eat a lot of grass, they need cellulase for digestion. That has got to do with appendix being long. Vegetarians have a high roughage diet. And what happens to the residue? So the digestion, the sigmoid continues to increase in size. They have a longer sigmoid than non-vegetarians. That's the logic. But the base is narrow. So it's a big loop. With a narrow base. It tends to rotate this way or this way. Which way does it go? Anti-clockwise in sigmoid, right? So it will go more this way because that's the angle at which it is attached. Cecal always clockwise because the way it is attached whenever it happens. So this is what it becomes the sign that you are referring to because sigmoid would be coming like this. So these are 3 lines seen. 1, 2, 3. And that becomes Freiman Dahel sign. Usually seen in vegetarians who eat a lot of roughage and sometimes it's precipitated by the taking of alcohol after that. And it can lead to sigmoid, ileosigmoid knotting also, which I've covered somewhere. And ileosigmoid knotting is when it's rotating, it drags along small bowel with it at the base, which becomes a knot. So that becomes ileosigmoid knot. And this can lead to ischemia and faster progression of ischemic damage to the sigmoid. Ileosigmoid knotting. Very important. So sigmoid volvulus, if you see the X-ray, first years and others, coffee bean, and 1, 2, 3 lines going to the right iliac fossa. So here it's an incomplete coverage. The greater trochanter should be visible in all X-rays, but you can see it here in this view. 3 lines converging, radiopic lines. Freiman-Dahel sign, right? And this is also called coffee bean sign. So it is usually seen in vegetarians, and they have it because the mesentery, the mesocolon is narrow. We call it mesosigmoid here. So therefore one treatment could be make the base wide, and that is called mesosigmoid plasty. What do you do there? This is your narrow mesentery. Make a vertical incision, making sure the blood vessels are not damaged, and then close it transversely, so the base becomes wide. Clear? That is mesosigmoidoplasty. But it can still cause problem. The other is to take away the redundant colon, but then the length is gone. But have we treated the patient completely? No. Third is sigmoidopexy. Fix it to the parietal. This is the worst treatment, according to me, because this becomes a focus for rotation then. But in emergency, when you don't have a very fit patient, there is a risk of patient dying of treatment, you can do sigmoidopexy and come out, because fibrosis will fix it. So then don't fix at one point, fix it constantly, multiple places, so that it becomes a, relatively a fixed structure. So sigmoidopexy, mesosigmoidoplasty, resection of sigmoid and colostomy, or anastomosis if the patient's Apache score is good. Understood? And ileosigmoid knot is also called as Gordian knot. Gordian knot is a Greek knot kept in a temple in Greece. So before Alexander had to go for conquering the world, his guru is very important, not teacher. Everybody is a teacher, gurus are few. His guru was Aristotle. Who?
Aristotle.
So he took him to this temple and said, can you open this knot? Because the myth was, if not, you can conquer the world. So he looked at it for a long time. Nobody could open it. The knot was very difficult to open. So he kept looking at it, and Aristotle kept wondering how is it going to do it. So he just picked up his sword and cut it into a piece. That's how I look. You will conquer the world. Right? So that is the Gordian knot, and based on that we call it Gordian knot. But it's called ileosigmoid knotting because it's a very dangerous, quickly progressing problem. So this is the same symptoms but exaggerated. So it kind of becomes small bowel is involved as well as large bowel is involved. Don't try to open the knot. If you open it, you will cause the same thing. Ischemic contents of the dead thing would become revascularized. That's dangerous. Chop, chop, chop. Stoma here and you're out. Do what Alexander did. That's exactly what I was saying. Don't try to untie it, which is too difficult to untie it. So what do? You would disconnect, resect, take it out intact. If there is no gangrene and you're very early, then that's a different story. You can untie it like a snake being untied and it falls back, but still you need to manage. So ileosigmoid knotting is usually seen in patients, people fasting in Middle East and in Ramadan, when they fast for prolonged periods and then they have suddenly a lot of food in the night. So that causes hyperperistalsis and that causes ileosigmoid knotting. Common in the south, after lots of these farmers' villages would eat a lot of rice in the night and then toddy. Huh? You take toddy?
Yes, sir.
So, but you know what it is?
Yes, sir.
Yeah. What is it?
So actually it is obtained from palm tree, extracted sap from palm tree.
So it's kind of a beer or alcohol, whatever levels are there, and that is what alcohol does again. So they have rapid movement and ileosigmoid knotting. I think I've done some talk somewhere, you can always follow it. Long one. Clear?
Yes, sir.
That's the management of these cases. I've told you all the management of sigmoid volvulus, ileosigmoid knotting, how to approach them, and how to approach the Gordian knot, which is the same as ileosigmoid knotting. Clear? Gordian knot. So remember Alexander and you remember the Gordian knot. And that, in this case, surgeon becomes the Alexander. He just clamps out. And a stoma. Whenever in doubt, take it out. Don't leave it inside. If you do, you're leaving a time bomb inside. It will open up any time. Because the Apache score invariably is poor in these patients. So they are not going to heal. Right? So don't only bail out the patient, bail yourself also out of it. So live to fight another day. Don't die on that day itself. You and patient both.
Yes, sir.
Clear?
Yes, yes.
Needless to say, you will resuscitate, you will build up the patient for surgery. Should not die of surgery. Optimization of a patient before any emergency is mandatory. We wheel in patients who are bleeding, that's okay. But we should not try to do something on a suboptimally managed patient.
He had a history of an unknown left upper thigh, sir, and knee left swelling, sir. He came to us in the emergency, sir. On examination, sir, he was tachycardic, sir. So local examination revealed blackish discoloration of the skin with a few areas of slough and pus, sir. We had made a diagnosis of necrotizing soft tissue infection post insect bite, sir. We had managed him with IV antibiotics, sir. We had done debridement, sir. We had sent for tissue culture also, sir. And we are doing daily debridement of the wound, sir. Antibiotics, sir, currently is on augmentin and dialysis, sir. He has no episode of fever, sir. The wound is also getting better, sir. We have put a above knee slab, sir, to prevent any contracture of the limbs, sir. And we are managing by daily dressing, sir. Only issue is HBS 6, sir.
So you heard it, no? Insect bite alone, mild problem, little insult, and the patient develop necrotizing soft tissue infection. The term is not necrotizing fasciitis, it is NSTI. Necrotizing soft tissue infection, which is usually symbiotic gangrene. Aerobes and anaerobes both are there, and this happens. Symbiotic means aerobes eat away all the oxygen, and the dead material is created, and anaerobes live in the absence of oxygen, and then they produce the food for aerobes, so they help each other. So release and surgical intervention is the key. And there is an NSTI index which you measure.
So there is an L-reading score, sir.
What is that?
Laboratory risk indicator for necrotizing soft tissue infection, sir. It has, sir, 6 components, sir. Hemoglobin, TLC, sodium, urea, CRP. One more, sir, I'm not remembering. But, sir, when we calculate it, sir, more than 6 is likely indicator of necrotizing soft tissue infection, sir. And there's also push test also, sir. If the surgeon who is doing the procedure, sir, if he is able to insert his finger without any force, sir, within the fascia plane, sir, that area is also involved, and that area likely has to go, sir.
Very good point. The push test is what we use in surgical practice. Very nicely explained, Karan. A good registrar would be visible. If you are pushing a finger and if there is no resistance, push test is what we practice in our unit, and that tissue is dead. Otherwise, every tissue has a resistance. And debridement is a term taken out of Latin. Debrima means to unleash. It's not the same as surgical toilet. We unleash till it, which means till it bleeds, we keep cutting. But don't cut a major vessel. The small, tiny vessels can be cut, and that's how we do that. And the entire thing is treated by good oxygenation, by opening it up. Anaerobes are taken care of. Dead tissue being removed will be a regular process. And never do all debridement on day one. It is serial debridements. Okay? And during debridement, Arun, what precautions do you take? What do you do?
Sir, during debridement.
What is the position of your scalpel?
So it should be parallel. We should do
Excellent.
debridement in layers.
It should be horizontal. I'll only ask one question and I'll know. That's like biopsy of a core biopsy to know whether it is benign or malignant. Grade, everything is known. So the core biopsy says he's doing well and he'll do well. Horizontal blade, but a vertical mind.
Yes.
Will you remember that?
Yes.
What do you mean by vertical mind, Aman? You've answered nothing today. Harry?
So you're thinking straight and you
Deep.
Tissue which is deeper.
The tissue which is deeper. The planes which are underneath, the vessels which are underneath. So whenever you're making an incision in surgery, it's very important to make sure that you are aware of the neurovascular bundle underneath. All incisions are parallel to it. Don't be direct on a vessel. Take a little zigzag so that when you close or leave it open, the vessel is not exposed. Exposing the vessel to the environment is a surest way to establish or to cause blowouts. Avoid that. Like you must have heard me say that in neck dissection. We don't take that vertical limb, bang on the vessel. We go behind and we take a little lazy as there. Good. So, mind goes deeper, scalpel goes parallel. And go in layers, never vertically. And use nothing else, not scissors. Use scalpel. Why not scissors, Rishi?
so
One end of the seizure, we cannot see the end of the seizure, sir. So
What is the end cannot be seen, but don't go that far. You see, any instrument which has got two blades will first crush and then cut. So if you're dealing with normal tissue, that will get crushed unnecessarily. Scalpel doesn't do it. Apple to apple comparison, scalpel is superior to scissors. With any instrument that has got two blades, will first crush and then cut. And crushing is not good. That leaves a dead tissue inside, which will tomorrow you'll have to cut again.
Yes.
So scalpel horizontal, mine deeper. And do limited debridement each day so that eventually you achieve the result. When do you put this patient on VAC therapy now? That's a protocol we follow. When would you do it?
Sir, when we are sure that there is no anaerobic infection,
How do you establish that?
so we will take deep tissue culture.
Very good. An excellent postgraduate will manage his patients optimally because he's understanding what he's doing. A monkey with a knife is dangerous. Why is he dangerous? He cuts throats of people unnecessarily. Surgeon with a scalpel is not a knife. Clear? So you must prepare the wound bed for vacuum assisted therapy because that is when you will be achieving. You don't want anaerobic environment. Why don't you want anaerobic environment in vac therapy? Gokul?
Sir, the VAC will already create an anaerobic environment.
Okay, shall promote? Because the whole concept is to create hypoxia for proliferation of vessels, for angiogenesis. So this would produce, this will promote the anaerobes. Right? Use that index, an STI score, for managing the patient. You know, work hard at creating protocols and scores in surgery, but then follow them like a gospel. Then only you get outcomes.
Yes.
Clear? Any other question? Any question here? Okay.